Joining me is Dr. Jack Taunton. He's a world-renowned sports medicine doctor and former chief medical officer for the 2010 Olympics. He's a co-founder and founder of Vancouver Sun Run, the Vancouver Marathon, and Lionsgate Road Runners Run Club. And he's here today to talk about return to exercise after COVID, the long haulers, and the importance of vitamin D. Welcome, Jack.
Well, Christine, thank you very, very much. Okay, and we're going to talk with Christine today about the return to exercise after COVID. Exercise, as we know, is critical for all of us, but particularly for anybody that has had COVID, to improve our immune system. We are going through two sets of, vaccinations, and when you've had your second vaccination, a lot of people think, oh, well, I'm ready to go. You're not ready to go, at least for 3 weeks, but your problem in terms of what COVID has done to you that's had COVID, it's been very destructive to your brain, your central nervous system, to the lung, and to the heart. These are the major areas, and then we'll go on to talk about those that have been so-called long haulers that have had at least 6 months of symptoms. And one thing that Christine started at the beginning was in terms of the one thing that they identified was that individuals that were hospitalized, 80% of those were deficient in vitamin D. And this was a Spanish study, and it was most significant in terms of its effect on males. And we don't know if it's because the disease reduced your vitamin D, and that's D3, or were these individuals deficient in vitamin D to begin with? But we do know it affects the males much more significantly than the females, especially if they're hospitalized. And they're had a much rockier road in the hospital. And when they were discharged, they found that these individuals, that their vitamin D, as I said, was 80% reduced. And as a means of prevention, and we're still, as I saying, trying to figure out, is this because you didn't have it to begin with, or the disease did it? But you need 1,000 international units of vitamin D is bottom line. So in terms of the effect on the brain itself, it is a result of an inflammatory storm, a storm of inflammatory cells that are involved in other conditions. But this is much more aggressive, and our own immune system exaggerates this inflammatory storm. And so people that have rheumatoid arthritis have too many inflammatory cells, and people with inflammatory bowel, asthma. But this is a significant effect from the cytokine inflammatory cells. And it wasn't until June, Christine, that they identified that corticosteroids like prednisone was certainly very effective in reducing the effect of the cytokine, the inflammatory cells. The other significant thing that the virus does is it stimulates the cells that produce platelets. And the cells that it affects are large megakaryocytes. They produce platelets, and that leads to a storm of emboli or clots. And this is in the brain itself in this situation. The treatment for that is aspirin, heparin, or oral or injectable anticoagulants to prevent these clots. It can cause an acute ischemic stroke. So it's a stroke, just like any stroke that somebody has, that they've had a blood clot in one area. And the area that that has been the most effective is the area that we see in individuals that have had concussion and particularly have had Parkinson's. It can cause a diffuse effect on all of the brain. It's called an encephalopathy, so that the whole brain gets affected by the inflammatory cells. And this may be part of the LongHaulers syndrome that we'll talk about in a few minutes, which gives people, they describe it themselves as a real brain fog. They can't think properly, their memory is impaired. Some will go unconscious with the effect of the platelets causing these clots. And as I mentioned, the effect is much like concussion and Parkinson's, where individuals get altered gait, balance, and you can imagine if you're a runner, or right now athletes like decathletes training for the Olympic trials and so on, it affects your gait, it really affects your balance, it affects your neuromotor dysfunction, your neuromotor control, so that that you're clumsy, you can't work alternately one arm and the other arm, or one leg and the other leg. And the big problem with this, and this was really seen with seniors with falls. And for the orthopedic surgeons that were working during the time when elective surgery was canceled and it was only emergency surgery, the biggest thing they saw were falls, and individuals would break their wrists, they'd break their hips, they'd break their, their ankles. So it really had significant effect, but it wasn't just confined to seniors, but particularly to seniors. A consensus statement was brought out last year for rehabilitation of individuals with COVID-19. And these were for the ones that had psychotic symptoms. They were individuals that had brain disease. They were very confused. They were hallucinating. And again, corticosteroids were effective in this situation. The longest follow-up is from China, where it started, in terms of the brain, and 27% of individuals had a significant depression. 42% had post-traumatic stress disorder, just like somebody that had been involved in a major accident and then following that had ongoing symptoms from this trauma. 13% had significant headaches. 16% were really complained of dizziness, and that probably is in fact an element related to their falls. 10% peripheral neuropathy, and these are people that are diabetic that have numbness and tingling in their feet, and that throws their balance off. Hence, your balance is off, and this is where we have to retrain these individuals. We need to retrain their balance, retrain their gait, and they get this numbing and tingling, and it's particularly in the lower extremity. And others will just get burning nerve pain that goes on for some time. 10% have symptoms of the musculoskeletal system, and this is often seen by individuals that get cramping in their calves, that are walkers or were runners. The muscles get very tight, hence massage could be effective. And there's one condition that was hadn't been seen very often, but about 0.5% of these individuals from China got a post-infective myelitis. And everybody says, what does that mean, Jack? The myelin is the lining that you gets impaired with MS, and it affects the spinal cord. And these individuals get flaccid paralysis. The muscles are paralyzed and they're very floppy. And so this is a very concerning. Fortunately, not that many people get it, but if you do get it, it's an extensive rehabilitation to regain that paralysis, regain that muscle tone with these individuals. In terms of the investigations, these individuals will have an MRI of the brain to see which areas are affected. The basal ganglia is the area that is really affected, much like Parkinson's. They do angiograms to look, put dye in the blood vessels and to see which blood vessels are in fact involved. And if it's something that really appears to involve a large amount of the brain, the individual would have a brain scan and the investigation in the progression of getting this individual back to activity. And now, in terms of the lung itself, that still also gets hit by this inflammatory storm. They get emboli, so they get clots in the blood vessels of the lung, and that's where you know that the oxygen is exchanged so that the individuals become hypoxic. So that part is critical. They get a type of pneumonia, especially along the borders of your right lobe, your left lobe, and the lobes of the lung. And in time, these areas of inflammation or pneumonia, they get fibrosis. These are the membranes of the lobes of the lung. And typically by about 6 to 8 weeks, all of a sudden these individuals feel they can't get in enough air. They have difficulty getting enough air and getting air out. So there's a restrictive breathing pattern that we have to monitor and follow so that we can, and this is a whole game of monitoring these individuals to make sure that this restrictive pattern itself is reducing and that they can breathe properly. Again, the corticosteroids are utilized in this situation. It's a very interesting thing, Christine, in terms of, as we say, pneumonia and or a special type of a pneumonia, and you get quite acutely, they get reduced oxygen saturation. Your saturation would be 99 to 100%, but some will collapse acutely. They will just collapse when the PO2, the oxygen level in the lung, and that's been impaired because of the fluid on it, the pneumonia, and the clots of obstructing the arteries. And when their oxygen level drops from 100 to below 90, they can just suddenly collapse. They're otherwise asymptomatic. They're not breathless, and so they call this a happy hypoxia. They feel at first their breathing is fine. Later on, we know at 6 weeks they'll have this restrictive pattern where it's harder. It's like asthma. It's harder to get the air in and get the air out. But with this happy hypoxia, they don't get breathless, and that doesn't occur until about 90, when they can collapse and some can die. And so the recommendation is that individuals that are being treated at home, or they're certainly being monitored in the hospital, but at home you can get at Shoppers, many of the pharmaceutical drugstores, or places like Paris Orthotics will have an oximeter that measures the amount of oxygen you've got. And the recommendation is, if that PO2 is below 93%, they should be in hospital on oxygen. You can monitor it at home as it drops, and people can function quite well at 95, 96. But once it gets below 93, you've got to get into hospital and to be on oxygen. So these individuals need to be monitored, and that if somebody in your house is being treated at home, you need to get for them a home pulse oximeter. And if it's below 93, you take them to the hospital right away. There are medications that we use those in when we had SARS, and when I was chief medical officer in 2010 with H1N1. And Remdesivir is one of the more popular and effective antiviral agents. And it prevents patients from becoming severely infected. And the ideal time to use that is before they get to the 93 level. And this was first identified in June of this year. If individuals are hypoxic, they do much better if they lay on their belly. And so if they're at home and you're monitoring them at home, and they felt that they were fine to be treated at home, and if they are short of breath, and remember, in many cases, they're not going to feel they're short of breath. But with your oximeter, if it's dropping to 96 and below, have them lay on their tummy, on their belly, and they do much better. During this period of time in Israel, they identified an agent called alpha defensin. It was produced by the patient's own white blood cells. And Christine, white blood cells fight infection. But this COVID triggers the white blood cells to produce this agent, which causes microclots in the blood vessels in the lung particularly. And this can be prevented by an agent which we've used for years. It's a potent anti-inflammatory, but was primarily used for gout, where individuals get the swollen great toe. Now they're using it for inflammation in the lung and also in the heart, and that's colchicine. So in this disease, older agents are now coming back and have been found to be very, very effective. So before we would allow you, and we've known you that you've had COVID, and I don't mean you, Christine, but a friend of yours or something like that, an investigation for return to sport. We need a chest x-ray so that we can identify if you do have this diffuse pneumonia, or you can see really thickened scar in the lung. So we have to monitor that and use that colchicine and wait until that lung is clear. We look at an inflammatory marker, CRP. We use spirometry, which is, and many of you have used that. Let's say you've had asthma, and it will tell how much air can you blow all the way out? Can you blow out 90% of the air? Is there restriction because of that fibrosis? And everybody needs to be tested on a treadmill and to identify your max VO2 and to see what your oxygen saturation is with exercise. And if that is below 93, for sure, you're not ready. You still need to be on oxygen before you can start exercise. So many people have not been evaluated, and they just start to exercise as a doctor, because most people don't realize the complications and the seriousness to the brain, to the lung, and we'll just talk about the heart now in a minute, the oxygen saturation, it's critical that you know what that is, because we don't want somebody to start out exercising and then end up collapsing or worse. So if persists, we do an MRI also of the lung. We do a lung scan to see where the circulation of the blood is, to make sure it's not obstructed by the blood clots. For sure, if you've had COVID, no exercise at all for 10 days.
Wow.
Then for the next 7 days, you're going to start a graduated walking program.
Yes.
And if that goes well with light exercise, then we start the walk jog program that we're all familiar with. And that's for 15 minutes to begin with. And the intensity is 70% of your maximum heart rate. And as you know, your maximum heart rate, you can easily calculate it. It's 220 minus your age. For me, that's at a heart rate of 147. So that's the intensity that I would do on a walk jog. And this is for 3 days.
3 days.
And it's for 15 minutes. And then if you're comfortable at that, your breathing is good at that, you're not getting headaches, you don't feel clumsy, then we increase the intensity to 80% of your maximum heart rate. And now we've increased it from 15 minutes to 20, then to 30 minutes. And then we will progressively increase that. And I've got a chart that I can show you in a minute. And we'll gradually increase that so we can go to 40 minutes and 60. And you can start to do speed work once you can do once you're comfortable at 45 to 50 minutes. So no exercise for 10 days after your COVID test has been positive. Once your symptoms are fine, then you're symptom free for 7 days, you're walking. Then light exercise, our typical walk jog that we would use, like from the sun run. And that's for 15 minutes at an intensity of 70% of your maximum heart rate. And that's for 3 days. Then we go to 80% of your intensity, and that goes to 30 minutes. Then we go to 40, 50 an hour. And during that period of time, we're increasing your tempo, your speed work, and then you can get back to competition. Mm-hmm. You return to the previous level if you're having difficulty. Let's say you got to 80% and then you feel short of breath. You feel your heart rate is much higher than it normally would be for that run or walk that you've done. And so then you've got to go back to the previous level. So the whole thing, remember, go slow and go gradual. And in terms of the heart itself, the heart is a muscle, and the COVID inflames that muscle, and in some cases, like a heart attack, kills some of the cells in your heart muscle. Your blood pressure is low, you're hypoxic because of the lung, because your blood pressure is low also, so your oxygen level is low, and you've been monitoring that. The receptor that controls your blood pressure and in many organs, the ACE2 receptor has been impaired, and people get arrhythmias, irregular, either very rapid heart rate, really irregular heart rates. And so this is an area that you certainly won't be exercising in. Mm. And again, this is a result of these pro-inflammatory mediators, the hypoxia. You get vascular inflammation in the blood vessels, the lining of the blood vessels, much like individuals that have had a heart attack. And this myocarditis and the acute cardiac injury can be determined by markers of damage. How much damage is done to the heart muscle? And the test is the new high sensitive form of troponin, and that measures damage to the heart muscle. And there's another agent, beta natriuretic peptide. And we can, if you've been sent for an echocardiogram, they can see whether you've got elements of cardiac failure, particularly where your left ventricle, the left side of the heart, which is the biggest stroke producer in your heart, and that will be decreased. And they can monitor the effect with the echo. And again, that's a result of particularly these platelet producers and clots in the coronary arteries. So we need to know how much damage has been done, how much inflammation there is in the heart, and what is the effect of these platelets on your coronary arteries, so that you can see how significant this virus is. Early on, everybody thought, oh, this is going to be like the flu. We'll be in a week and we'll be back to exercise. No, use exercise with this picture of acute cardiac heart muscle damage. And we can monitor that by looking at these markers. And coronary arteries are obstructed. these individuals can collapse, and tragically, there's been a number of deaths, as we've heard, from this. There's a whole host of abnormal electrocardiographic abnormalities. One, it may be simply your heart rate's much faster than it normally is. They can be some that are just triggered from the ventricle, from the big pump, the left pump, and where you get these ectopic beats. You can get blocks between the conduction from the atrium and the ventricle, which coordinates the filling of the heart and then the pumping of the heart. And it's primarily left, but you can also get right ventricular strain pattern that we can identify. So you can see monitoring these ECG abnormalities is really critical, because some of these can trigger the equivalent of a heart attack. The voltage of the amount of electricity that your left ventricle can generate, and it should be a high level, it's called the QRS complex. And is this low because of the swelling in the heart muscle, or it could be because of swelling in the lining of the sac that the heart is in, the pericardial sac. So we need to monitor what the voltage is. And it's really critical because, as I mentioned, many physicians don't understand this. Those that are strength and conditioning coaches, certainly the majority, and we're out speaking. I just spoke to all the first year, 200 first year medical students, to get them educated right off the bat. And I've given well over 30 of these presentations so that those that are exercise leaders understand what they're dealing with. So the investigation, we do a 12 lead electrocardiogram to take a look at the voltage, to look to see if there's evidence of lack of oxygen to the heart, and those are called T waves. A Holter, that's a 24-hour monitoring your electrocardiogram. The echo to see if there's any evidence of heart failure. Again, we look at this inflammatory cell. We look at those markers, the troponin and the beta natriuretic protein. And so these are key so that we know how much damage is done, and we need to know that that is gradually improving. It can affect the kidney, and we need to get a complete blood count to see exactly how many platelets, those cells that clot your blood itself. Then we'll do an exercise stress test, and we've coordinated with Sport Cardiology BC, which is out at UBC, with Dr. Saul Israel, and Saul and I started this program some time ago. And so you can just call, there's no charge to it. You call Sport Cardiology BC, and they will do a complete cardiac test. They may do one to take a look at how much blood supply you're missing, and that's so-called the MIBI scan. And again, you can look at an MRI to document injury, how much injury, just like with a heart attack. So in terms of, we've got back, like we said, we got you 7 days, 10 days you haven't done anything. 7 days you're gradually starting a walk run. We know we're going to start you at 70% of your maximum. We'll do that for 15 minutes for 3 days, and then the 80%, and then gradually increase that. But if you start to develop symptoms again, and these symptoms may include just an elevated heart rate. I know I would do this run around the neighborhood and my heart rate would be 110. And if it's 130, you've got to go back and be reevaluated. If you have exertional shortness of breath or exertional dyspnea, that is a sign that you're not ready to progress and you need to back up. If you have an elevated rate of perceived exertion, this is much harder for me to run up this little hill than it normally would be. And if that has occurred, you've got to back off. You've got to go back to the level where you can do that. And if your elevated heart rate at a submaximal is still staying high, then it's going to take longer for you to be able to start that progression itself. If, unfortunately, you develop the myocarditis where the whole heart is got inflamed, this is a period of 3 to 6 months of complete rest. There's one pro football team that 12 individuals all have had myocarditis, and they haven't been able to do any exercise for 6 months. It's that serious. Then it's monthly electrocardiogram, the Holter, the echo, and the lab work. And you can resume training if you've had your doctors told you got a myocarditis. You can resume training if your echo shows your left ventricular function is pumping normally. The serum markers, the troponin is normal. Your electrocardiogram over 24 hours is normal, and you've had a normal exercise stress test and your oxygen level is normal. If you're at that, as somebody that's had myocarditis, they can then return to exercise and ultimately to competition. So this is from the British Journal of Sports Medicine. It came out on June the 22nd this year, and it looks and it goes through what exercise is allowed, what percent heart rate, and as we said, 70, then 80, then 80, but at a higher, a longer period of time. What's the duration? And then at the beginning, the duration is 15 minutes. Then it's 30. Then we'll take you gradually to 75 to 80. Then you're now ready to start training and return to your normal exercise, running or cycling level. And so that's why the monitoring is so critical. We have to monitor the cell damage. We have to monitor your electrocardiogram. Now you can return to competition, and you can get this and you can print this out yourself. British Journal of Sports Medicine, June 22nd edition of June of 2020. And if you can't find it, Christine could certainly help you find that, because this is your Bible at getting back to competition. Mm-hmm. Now, we've heard of long haulers, and the early history that we had out here was there was 3,000 that first were identified with symptoms over 6 months. Many felt as if there was no help available. They felt alone. They were depressed. And many had not gone and got a test and hadn't been assessed by their physician, and certainly hadn't been assessed through sport cardiology. The first clinic was at St. Paul's Hospital. It's on the 5th floor of the Burrard building. Now there's a clinic at Vancouver General and another one in Surrey. And there's 3 in Ontario studying the long-term effects. So that was 3,000 before a clinic was developed. These were individuals that kept quiet, but were frustrated. They'd talked to many people, but they never got any answer, and they just felt alone and hadn't been investigated. Obviously, they needed to be investigated right away. And for these, the first symptoms that we started to see these come out was they now have fever, intermittent headache, muscle pain, tachycardia, higher heart rate, and lower blood pressure, fatigue, nerve pain, as we said, the numbing and tingling, particularly in the feet, shortness of breath, poor exercise capacity. And one of the classics in the early phase was they were unable to climb stairs. They had a loss of short-term memory, and they had this brain fog, which we now know is a critical symptom that tells you that you still are in for a long ride. Some will have seizures, and we don't know why, but many of these early people we saw were complaining of hair loss, just like people that had thyroid problems, and they would lose their hair. And so that was one of the early signs. Symptoms now identified by the Center for the Disease Control in the States and other, that they've now expanded this symptom list. The top ones: fatigue, shortness of breath, a return of cough, joint pains, just like you've got arthritis, chest pain, and this brain fog. And that's difficulty thinking and concentration. That is an important one. The other group then came on depression, the muscle pain that we talked about, where the muscles are stiff, they're sore, they're cramping. Massage can help. Headache, intermittent fever, and this fast beating or pounding heart. And the more serious long-term complications, and we've talked about those, the inflammation of the heart muscle, the myocarditis, lung function abnormalities, as we talked about, the pneumonia, the fibrosis, and the inability to take in a deep breath or blow all the air out. They can develop acute kidney injury and have blood in the urine, or the kidney tests are abnormal. A rash, hair loss, and what many people, it was identified relatively early on that it wasn't just fever and cough, but the earliest symptom was a loss of smell and taste, and the memory problems and anxiety. So this is the group that these individuals have by far to be the most common. A senior administrator of 2 long-haul COVID fighting groups that was established in Facebook. And those numbers are now over 8,000. Physicians at a central Paris hospital reported 30 long haulers every week with an average age of 40, and women outnumber men 4 to 1. Why? We really don't know. A recent survey in United Kingdom identified fatigue as the most common symptom, followed by muscle or body aches, shortness of breath, difficulty breathing, and difficulty concentrating. And that ended up being that brain fog. And cough in a center, a large medical center in New York, in their long hauler clinic, cough was the most common persistent symptom itself. As long haulers were followed, the most debilitating symptoms were impaired memory, followed by fatigue. And this was identified as occurring when the brain fog doesn't lift. That's where these individuals fit into this group of long haulers. That brain fog has not lifted. In an Italian study, the most common symptoms reported at follow-up were fatigue, shortness of breath, joint pain, and chest pain, in that order. No fever and no sign of any acute illness. But in their program, as individuals were improving fatigue, the shortness of breath was still present, joint pains and chest pains were the most. And unfortunately, 44% of those reported at 6 months, their quality of life, as you can imagine, was impaired. Less formal surveys have turned up wide-ranging lingering effects. And there's been one large group called Politica, COVID-19, and it conducts its evaluation through online surveys. And to begin with, 91% of 640 respondents had not fully recovered. That's when they first started to see this happen. Most reported ongoing fatigue, chills and sweats, body aches, headaches, brain fog, and gastrointestinal issues. And that was the first group where people started to talk about diarrhea and constipation. This group now, through this online survey, is now more than 14,000 members. And so that the numbers are increasing. The most concern included, again, the oxygen saturation levels as low as 88%. And so that's why it's important. This group, and if you're in this group, you need to be using that oximeter and see where your oxygen saturation level is. And if it's down at 88%, you still are a candidate to be on oxygen, and you certainly are not ready to start exercise. And 8 to 10 minutes bouts of high heart rate, averaging 135 beats a minute, at least once a day. So that with the increased monitoring of this, we have seen other symptoms come up, including the GI tract, certainly the ongoing low oxygen levels. One theory, this syndrome was highly suggestive of chronic fatigue syndrome, which is like what we thought was the syndrome related to mononucleosis. And it's an encephalomyelitis, encephalo, the brain, myelitis, inflammation in the brain. And Dr. Hornig, he's a member of the Columbia University Medical Epidemiology faculty, and her group pointed to autonomic, which is fight or flight, nervous dysregulation, as the most possible explanation for long haulers the tachycardia, the fight or flight, extreme fatigue. But then most recently, Dr. from Stanford, neurologist Dr. Miglis, who specializes also in this autonomic nervous system disorder. Everybody was sort of thinking that this is where it all sort of came from. And his work was on postural, means you stand up, orthostatic, you stand up and your blood pressure drops and then your heart rate goes up. And that condition is called POTS. And he, though, has just co-authored a case report with the most common symptom of this postural, you stand up, your blood pressure drops and your heart rate goes up. That is from the fight or flight system within your nervous system. But he felt the most common symptom for the long hauler was the persistent brain fog. And that was the longest to go away. So I hope this gives you an idea of the seriousness of what COVID is, how it affects the brain, the lung, and the heart, and why it's so critical to have somebody monitoring you. And here in Vancouver, we're very lucky with Dr. Saul Israel and his team at UBC with the sport cardiology program. You will be assessed. They put you on the treadmill, they'll take the blood tests, and they will be able to tell you when they do the echo and see if there is any evidence of heart failure. And they'll be able to monitor you and tell you when the 7 days can start, that you can start the walk-run program and the gradual return. And this is not, early on, everybody used to think this was just older people. It is not. This involves young individuals and it involves young, previously very active individuals. Good friend who is a top mountain bike rider. She's also a dancer. At 6 months, she could hardly push the pedals. And it's that bad. And we really, and if you've got friends that still got ongoing symptoms, we now have 3 clinics at St. Paul's, VGH, and in Surrey. Particularly if you've got any rapid heart rate, irregular heart rate, your blood pressure is low, you feel dizzy, make sure you're seen by Sport Cardiology BC. So Christine, I hopefully that will give your listeners more information to realize they need somebody that really understands what this disease is before they get you back exercising. Because we have seen too many people collapse and tragically die because of one of these fatal arrhythmias, or your heart has been significantly affected with COVID. And the one thing, we're very fortunate now, where many people are getting into that second vaccine. But again, you still have to go through this process to make sure that it is safe for you to get back to exercise. It will, 3 weeks after you've had your second week, Cheryl and I just had ours a week ago, and we know it's 3 weeks for me because, and there'll be other people like me that have had chronic infection, their immune system has been impaired. I'm going to be out at least another month after that. And we need to make sure that we are evaluated and we are monitored and individuals are following us. You do have an oximeter and you want to make sure that is close to 100%, so that these individuals can get back to exercise safely. The other concern is we hear about these other strains from England, from South America, from Argentina, um, uh, and these, and from South Africa. And these other strains, fortunately, to this point, all of them appear to be affected by the vaccine and give you an immunity to that. But there are so many of these strains that are developing almost weekly around the world that we have to watch carefully to make sure that your immune system has been improved by your vaccine. And soon they're going to be announcing that you can get a blood test done to make sure you got the antibody to COVID and that your exercise response on a walk, jog, program progression that continues to improve. And if it doesn't, and you get any of the hard issues that we've talked about, you get out to UBC and be evaluated there. So Christine, thank you very, very much. And I don't know if you have any questions yourself, but you're more than welcome to utilize this presentation. And we will do other presentations as we've done over the years, and it's always a delight to work with you. And we are so lucky, Christine, that we have somebody as dedicated as you are to the exercising population. And right now, this is such a critical component in terms of getting these people back to exercise so they can improve their own immunity on top of the vaccine, because exercise is critical. But remember, it's walk before you run. We've got to go slow, and we've got to monitor our blood pressure, our heart rate. You've got to be followed by your family doctor, and particularly we've got sport cardiology, and be evaluated there. So thank you very, very much. And we will be talking to you soon.
Thank you very much, Dr. Taunton. It was great information, and thank you so much for your time, and we'll do this again.
We will.
Yes.
And great to see you again. And you really are tremendous. So thank you very, very much.
Thank you.
Goodbye, everybody. Stay safe.
Yes.
Remember to increase slowly.